Hi everyone, welcome to this lecture on behavior therapy. To get us started, we're going to talk about a couple key terms in relation to behavior therapy. And this first one is operant conditioning, which you might have heard of before. Very famous B.F. Skinner, the idea that rewards and punishments increase or decrease behavior. So if I give rewards, to, let's say with children, I think this is the easiest way to think about it. The sticker charts, if they do a good job that week in school, they get they get a sticker for that behavior. That's the reward. And the punishment might be that if they don't do any of their work and they don't have enough stickers on their board, then they won't get to get a treat at the end of the week. So that would be operant conditioning. And then classical conditioning is Pavlov, who you might have also heard of. But essentially the idea through his experiment with his dog is that if you have a neutral stimulus with an unconditioned stimulus, you can trigger a response. So if in his experiment, he rang the bell every time the dog was fed. And then when he rang the bell without food, the dog still salivated and still expected to get food. So two key terms. And out of their work came the social learning approach and cognitive behavioral. So the first thing to understand is that cognitive theory acts as a bridge in some ways between psychoanalytic theory and behavioralism, in that with cognitive theory, thinking is a behavior. Albert Bandura combines the theory, combines the idea of behavioralism and bridges it to include observing, thinking, and behaving to form social cognitive theory. And of course, cognitive behavioral therapy is the combination of cognitive theory and behavior theory. And so behavior theory is, because it's all based on things that are measurable, meaning I can see them, as opposed to psychoanalytic theory where we're looking at mental models. We can't necessarily measure those ideas. But with behavioralism, we can measure the idea, and that makes the intervention very friendly to experimental settings, so that you can increase or decrease a particular reward or punishment more easily, which makes it much more, there's a much larger body of evidence to support its use with clients. And behavior therapy, a therapist using behavior therapy would be very active and directive, would be providing psychoeducation. So, maybe a workshop on medication management or stress reduction, how to, have good hygiene, how to talk to your family about your bipolar disorder. All of that might fall under this umbrella of behavior therapy. And it's not a real insight-oriented approach, right? Because we can't, it's not real easy to measure insight, but we can measure behavior. And a very famous model and is the ABC model, antecedents, behavior, consequences. So something happens, then there's a behavior, and because of that behavior, I experience a consequence. So let's apply this. The first step is, that I have a child, and every time we go out the checkout aisle, the child wants candy, because it's always right there. And I don't want the child to have a meltdown in the store, so I just give the child the candy. The problem is now that the child expects to get candy every time we go to the store, and I become unemployed and can no longer get my child candy every time we go to the store. So through this model, first we're going to look at, okay, the antecedents would be, what the environment is. So the environment here is the store, and that the child thinks that they're going to get the candy. The behavior in this case is that, I've allowed the child to have the candy, and so the consequence of that is now the child expects the candy. And so I'm going to have to do something different behaviorally in order for that child not to expect the candy. The same thing could be said for negative thinking. So I have a test coming up and I get all worried about it and stressed out. And so because of that, I can't really retain the information. And then the consequence is that I don't do well on the test. But usually what ends up happening in that case is that the client then internalizes the situation and says, that I'm just not good enough, rather than recognizing how their behaviors, the way that they're not dealing with stress well, is setting them up to not be successful as the consequence. So this is a very active and directive approach, and we would teach the client the ABC model, and we would have them do it regularly with us in session. And we're going to have positive and negative reinforcement. In this case, with operant conditioning, positive means is not good, or it's positive means I'm adding a behavior, and negative reinforcement means I'm taking the behavior away. And ultimately, we're looking for extinction, so the behavior doesn't exist anymore. So let's apply an example here. Clients in early recovery are encouraged to go to AA or other support groups because they need to change their environment in order to not experience cravings as often for their drug. So they're encouraged to go to support groups as far as their treatment and recovery process is concerned, because it'll lead to a greater possibility of the extinction of the behavior, which in this case is using substances. And progressive muscle relaxation is a very popular way to help people work with their stress, and it's a way of squeezing different muscle groups slowly and then letting the muscle go. So I am squeezing my hand and then I'm letting it go. And I would start at the top of my head all the way down to my feet. And a behavioralist, in behavioral therapy, we would teach our clients progressive muscle relaxation, and we might ask them to do it once a day as their homework. And then we have systematic desensitization, a very popular intervention for treating phobias. And here we're using principles from behavior therapy, and we're slowly teaching clients relaxation techniques. And then once we establish together that they are feeling safe enough to begin exposure to their anxiety that they have, then we would gradually expose them to the anxiety. So an example would be my brother very much suffered from generalized anxiety disorder. One of his phobias was that when he was little, we're talking like 6, 7 years old, was that he was going to get locked in the mall at night when they closed. So first, he actually participated in some of the first early studies of systematic desensitization here at Temple University in their trial studies. And they first taught him a whole bunch of a whole bunch of relaxation interventions, and then they would go to the mall and gradually each session they would stay a little bit later at the mall until they stayed at the mall past closing. And my brother's 35 now. He says that having had that education and experience for the treatment of his anxiety as a child has still helped him to this day. And so these exposure therapies seek to, again, you're going to very gradually expose the client to the anxiety provoking situation. And eye movement desensitization reprocessing, which is almost always referred to as EMDR, is becoming a much more popular treatment for trauma. So during EMDR therapy, the client will attend to, emotionally disturbing materials, something that's caused them trauma, in brief sequential doses, while simultaneously focusing on an external stimulus. The therapist will direct lateral eye movements, usually with their finger, which is the most commonly used external stimulus. But there's a whole variety of stimuli that could be used, including hand tapping or audio stimulation. And Shapiro, who developed this intervention, they hypothesized that EMDR therapy facilitates the accessing of traumatic memory networks so that information processing is enhanced with new associations forged between the traumatic memory and more adaptive memories or information. These new associations are then thought to result in complete information processing or new learning, eliminating the emotional duress and development of cognitive insights. Social skills training is very common. I can't think of a community-based mental health center that does not offer social skills training in some capacity. How to make friends, how to be assertive, communicating well, healthy relationships, all of that could possibly fall under social skills training. And then we have multimodal therapy here, which is a very popular approach to psychotherapy because it's a much more holistic approach. And Arnold Lazarus, who came from behavior therapy, developed this approach. And it's based on the idea that humans are biological beings that think, feel, act, sense, imagine, and interact. And so when we're treating that individual, we have to address each of these modalities or each area in their treatment. And the acronym is often called the BASIC ID. Dialectical behavior therapy, which has become very popular. Marsha Linehan, I encourage everybody to take a training on this if you can, because it's so wonderful. Started out as an intervention to treat individuals with self-harming behaviors who were suicidal, has now been applied to multiple contexts, multiple concerns. There's a really good DBT skills book that I recommend everybody get. I use it in therapy all the time. But rather than challenging thoughts, which is real typical in CBT, right, that we engage in distorted thinking. Here we are in the middle of the pandemic. Everything feels for many so out of control. People are isolated. It could be real easy to get overwhelmed in your thinking. But, rather than challenging those overwhelming thoughts, a DBT therapist would work with their client on acceptance strategies and then change-oriented strategies. So I'm going to accept radically that this is what's going on in this moment, and what is within my purview to actually change. And it's a very skill-based therapy in that way. It's a pretty intense treatment. It's got, the client would go to a psychotherapist for their individual counseling, then they attend a group, then they have a skills group, And the therapist who does this actually has to be available for their client all the time. That's one of the stipulations of this approach. The client can call the therapist at any time if they're struggling with self-harming behaviors. Now, during that phone call, the therapist is not going to be doing therapy with the client. The only thing that can be said over the phone is the therapist can reinforce the skills for the client. That's it. Anything else has to be talked about at the following session. But that's a huge commitment to make, and so uh, many therapists don't practice dialectical behavior therapy in the full form. And then there's lots of behavior related mindfulness interventions. So mindfulness-based stress reduction, it's an 8-week model where you learn mindfulness to reduce stress. We have 2 really famous centers for this in the area at the University of Pennsylvania and at Jefferson Hospital. I've taken the mindfulness-based stress reduction course at Penn and highly recommend it. And it is very behavioral, so you are expected to do 45 minutes of meditation at least 6 days out of the week. You are journaling about it to keep track, and you're going to a group for 3 hours once a week. And it really is focused on using mindfulness as a skill, and it is not a psychotherapy. Then we have mindfulness-based cognitive therapy, and again, rather than challenging thoughts, we are working towards acceptance, and we're integrating parts of Kristen Neff's self-compassion approach, which is also a mindfulness approach. And so we're integrating cognitive therapy with mindfulness-based ideas. And it's a really easy approach to use, and there are lots of good workbooks on Amazon for this kind of thing. I highly recommend you get some. You can also Google for worksheets. It just gives you a place to start once you start running groups with clients. Acceptance and commitment therapy is focused on non-judgmental awareness and the idea of acceptance, and that we can be flexible. There's this really famous image that I always see in relation to acceptance and commitment therapy, where a monster is sitting on the couch with a little kid, and the monster is the kid's fears. And the idea here is just that, I don't have to react to my fears. I can learn to sit with them and not react to them. There's also a great degree a focus on values and how the client can live into their values. So behavioralism is, has cross-cultural appeal because it recognizes the influence of the environment on the person. And yet, at times, if the approach is being applied too narrowly, and I'm too focused on behavior change, you can miss other components of interpersonal or cultural dimensions that might be influencing the client's problem. So we have to be careful that when we're working with a client, that we're clear that their depression is just not because of their stinking thinking. A person of color has a real reason to be depressed and overwhelmed and traumatized right now. So that's sort of what they're alluding to here. You don't want to give too much responsibility to the individual and not recognize the systems that they exist within. That said, behavior theory has contributed to a boatload of therapies and therapeutic approaches. And because there's a large evidence base and we need to, as counselors, use evidence-based practices, it's also a very popular approach. And, I think, again, when we're looking at limitations here, there isn't a great emphasis placed on insight. And so when the client has a long history of what is now referred to as complex trauma. So let's say they've been traumatized because they had dysfunctional, were raised in a dysfunctional family and have a lifetime of trauma. You can't necessarily just extinct certain behaviors to get out of that experience. You have to also pay attention to the relationship between the client and therapist. That's also critical to the client's healing. And there's not a great emphasis on insight. And because you're really paying attention to symptoms, so you are, helping somebody to deal with their stress, doesn't mean that you're necessarily going to be able to help them get out of the stressful situation. And or, again, if they've had a lifetime of trauma, you can help them, with behavioral therapy around symptoms, but that might not get to the underlying issue. Uh, there is always potential for manipulation, but ultimately that's really about the client's trauma, and it's important for us to recognize that. And finally, we want to be sure that, we're not adhering to the behavior change or the worksheet or, whatever the client is working on too rigidly. There's an opportunity there for that if we get too anxious. But we really want to, at times we're going to need to pause and explore the difficulties with the client and not just keep pushing forward, behaviorally and ignoring the client's lived experience in the moment. So that is behavior therapy in a nutshell. I encourage you to look up lots of articles and take a look at how this does or does not fit within your own emerging theoretical orientation.